Now it's the time for questions for our panelists. I want to just point out that this session came out of a project in the Fielding School of Public Health that has been directed by Cindy Kane with guidance and some funding from Tom Weinberger. This topic can be emotional for many, and I ask that these are respectful questions of our panelists rather than statements about people's personal opinions. And with that, we have questions. I think we have microphones.
It should be turned on.
Questions? We have one here or there? Yes. Dr. Stone.
Yeah, so I'm from the Cedar Side. Thanks to panelists for a very interesting discussion. I would ask Dr. Puri if, after hearing Dr. Ganzini show that most patients who were requesting this, the vast majority, do not have important symptoms as a motivation, if it makes sense to have a mandatory palliative care consult, because for patients at the end of life, that might seem burdensome, another hurdle for them to overcome if they're really trying to relieve their own suffering.
My microphone works. Okay, perfect. Just wanted to make sure. So thanks for asking that question. I think, the distinction, what I would say is that palliative medicine isn't just about physical suffering, that there's quite a lot of existential and spiritual suffering that at least the patients I've seen in my career come with, and that influences, and there's a complex interplay between the existential, spiritual, emotional experiences as well as their physical symptoms. And it's not to say that there aren't some patients who I've come up against a wall with even the very best palliation that we can offer. There are always going to be those patients who say, I am suffering too much and I would like to exercise this other option. But I don't think that's a reason to deny them the opportunity to engage with a palliative specialist. And I think that can make their quality of life better.
Go ahead.
So in our studies, we found that if a patient makes a request before they go in hospice referral is the most effective intervention for the patient to consider another alternative besides physician aid in dying. The second thing is, I think even if the patient chooses physician aid in dying, their quality of life will be better before they die. That they will, and many patients who want this choice are suspicious of hospice. They're suspicious of more care. They don't like the idea of nurses coming around and poking around in the refrigerator. And so that, but if they can be convinced that hospice will help them improve, have more control, and that they can accept as little or as much hospice as they want, I think the quality of their life is better, no matter what their ultimate decision is.
I just wanted to comment, looking back to the 1990s in Oregon, and I'm thinking of a colleague of Dr. Ganzini's, Susan Toll, who ran the ethics center there and was also involved in palliative care. And she remarked that at that time she had great difficulty getting Oregon physicians to come in and learn about end-of-life care and the various ways in which particularly palliative care could be of benefit to their patients. But as soon as the is it called Death with Dignity in Oregon?
Yes.
Yeah, the Death with Dignity Act was passed in Oregon. She couldn't run enough seminars. They were just all oversubscribed. And her explanation from talking to the people signing up was that they had previously been able to tell their patients, if they raised it, reflecting what was their own discomfort. I can't talk to you about that. We just don't do that in medicine. The patient would say, can't you help me die? Can't you give me something that I can take that would... No, we just can't. But once they couldn't say that anymore, they needed to understand palliative care. And I see, because I very much supported the policy that Dr. Puri described at USC, in part is another way of not just reaching the patient, but reaching the physician. and having the physicians see the kinds of things that are available, because there's no way even an excellent physician like Dr. Puri is going to be able to get to every patient who needs it, not only those who are raising the prospect that they want physician aid in dying, so, or physician-assisted death. So it would seem to me that part of the rationale that one could say is it's part of helping the patient and educating the attendings about the things that they should be thinking of routinely.
I'm Shane Cuby, Environmental Health Sciences. I'm curious about Oregon and the potential application of to California of this act to prison.
What was it?
Not sure we heard the last word.
Prisoners. People who are in prison
Yes.
and who are incarcerated and who want to end their lives.
My prisoner.
Yes, I am not aware of this occurring in prisons. So any healthcare system can, by policy, decide that they're not going to participate. For example, the Catholic hospitals contractually prevent their physicians from participating in the act. And I suspect that the prisons would also do that, even though our prisons have pretty good hospice units, because we do have many aging prisoners who die in prison. So, but I'm not aware of this occurring in prisons.
I think that is a prison, as Dr. Genzini said, I think that's a prison management issue. And from what I have read, most people on the prison side would regard it as potentially a very disruptive thing in the prison setting. And there are a number of things which people can do that prisoners can't do in the medical area. Obviously, there are many things that prisoners can't do. In the medical area, since the since the early 70s, mid-70s, prisoners are not used in research unconnected with their illnesses or the conditions of incarceration. Now, the thought there is that prisoners are not free, they are less free to make decisions, and the decisions they make are more subject to control by the people who control their lives. And so we would have questions about their independence. So both from the prison management side and from the ability to make an unconstrained decision side, there could be reasons not to allow the application there.
I think it's fair to say at this point that it's conjecture and would have a lot to do with whether the prison health system opts out, which I have not heard about. We have another question? Oops. Yeah.
My thought is that the California Supreme Court in the Thor case said that a prisoner had the right to refuse treatment. And so it's hard to say how this would play out in the event of a challenge by a prisoner saying, I have the right to avail myself of this law. But it's possible that it could be decided that prisoners have the right to do that.
Terry, I would agree with that as a possibility. The distinction, in my view, would arise from the basis of the decision to say that prisoners cannot be forced to undergo treatment which they object to as a general matter, and that isn't what they're sentenced to. In other words, they're not sentenced to accept treatment. That's not what is happening here. And so avoiding that intrusion seems to me not necessarily the same as the other. But as I said before, I can well imagine that this act is going to face people saying, I'm not covered by the act, and I should be, and I'm being deprived of a right. So having created this right, you have to distribute it to everyone who wants to use it. So I could imagine that prisoners might be one more category of that sort.
Okay, we have a lot of questions. Let me ask you to introduce yourself as you ask your question.
Oh, I'm Ann Kelly. I'm a lawyer, and I went through the EMPH program over here a couple years ago. I just wanted to comment on the palliative care requirement question from the gentleman from Cedars. Just wanted to suggest that another good reason for having that requirement is to maintain public trust in both the law and in the institution that they're going to implement it. Because people are going to have that on their minds.
Thank you. Next question. We have a lot of hands up.
I'm Dr. Pawson. I'm from Ventura County Medical Center. I'm the Director of Palliative Care there. And Dr. Curry, I'm curious as to when you wrote the policy for USC, what did you do about the participation of residents and fellows in this act? I'm obviously licensed, non-interns, but since all their work's done under the director and direct supervision of their attendings, do you permit residents and fellows to be the attending physician and or the consulting physician?
Thanks, that's a great question. And there's two ways I'll answer it. One is by saying that no house staff, so no residents or fellows, can be the one to participate in the law, either as an attending or a consulting physician, because ultimately everything they do is supervised by their attending physician. So that decision was made because of that. That's kind of how the chain of command works. And there were attendings who felt that, if there's a disagreement, ultimately it is the attending who has to account for the decisions made in the patient care. That said, it is really one of my concerns and the concerns of my colleagues has been that it is very distressing to get those requests when you're a trainee. When I was a trainee a while ago, I would get these requests far before this law was passed, and just hearing someone say, will you help me end this, in its various ways that it's presented is very distressing. It's distressing for nurses, it's distressing for social workers, it's distressing for everybody, regardless of whether someone's specifically asking for the End of Life Options Act. So one thing that I think needs to be augmented is just support for people who have gotten a request and are bothered by it or not sure how to navigate it. And the kind of informal policy is that if anything happens along those lines, that anyone's free to call our office, and myself and my social worker kind of help triage any of those calls. We haven't had a whole lot of them, but with informal conversations I've had with the residents and fellows who consult us, I know that this is on their mind, as is, the impact of stopping a certain kind of life-sustaining intervention, even before we're talking about the End of Life Option Act. So in general, I think we need to do a better job of addressing moral distress of our trainees, but certainly in this context.
I can add that UCLA, both the attendings and the consulting physicians that have participated have made a point of involving a fellow or resident in every visit. And that's the point that they've made to me. They want that to be part of their education. Next question. How do you want to do this?
Saul Agilat, I'm an attorney, but I am a graduate of the UCLA School of Public Health. I'm troubled about the position of the physician in this decision-making process. When we know death is imminent and it's going to be a few days or weeks, it's easy to exercise that judgment. When you go back 6 months, what is the degree of certainty that's going to allow the physician to make that decision? And I'm particularly concerned when I see the statistics that where the physicians appear at this point, at least, many of them reluctant to make that decision. So what is going to be the standard there, particularly where the patient is requesting it and the physician doesn't really think that she is going to die within 6 months? What does that cause to what occurs to the physician-patient relationship and so on?
Dr. Genzini, can you comment whether prognostic estimates were a problem for the physicians?
So prognostic estimates depend on the disease process. For some like cancer, there's much better measures of prognosis. We know, Neil and I have a colleague, Nick Christakis, who did a study in patients, I think going into hospice, that showed that physicians overestimate life expectancy 5 times more than they underestimate it. So our errors are mostly that we overestimate life expectancy. But be that as it may, there are about a third of patients who receive lethal prescriptions in Oregon don't take them, and some outlive their 6-month life expectancy because of that uncertainty. We know that patients that go into hospice, especially patients with neurodegenerative disease, get really good nursing care in hospice and get better and get discharged from hospice. I've had a couple of patients who've been repeatedly discharged from hospice. So, but even if there is uncertainty from the patients, as Dr. Camperon has said, maybe some of that's arbitrary. We tie it to the 6-month prognosis because we want to make sure everybody who makes this decision can access hospice at the same time. But from the patient's experience, it's not only about that they can see the end of their life, but they see a functional decline and a decline in their abilities to do the things that are meaningful for them. And they're experiencing that. And there could be uncertainty, but I think that's rare.
And it's important to remember that the 6-month magic number came in because of discussions among the actuaries at Medicare, who were trying to figure out what they could predict well enough to be able to say that this was not going to be a budget buster, that is to say that people, given a new service, but not at the time, it was much more categorized. You couldn't get the curative service you were going to get, but how long would they live and what they had data about. And they were able to say, well, let's say 6 months. We can give a 6 month. And then it migrated out of what was an insurance decision into these statutes.
Are you saying the patient is just a statistic?
To the actuary, yes.
Next question. Hi, I think your comments about. Hi, it's Richard Singer. I'm actually adjunct faculty at Hopkins in information sciences, and also quite religiously observant. So it's very interesting that distinction that you make it between active versus passive. I think it's really important. But I'd love to, and Julie, so there's 2 questions. One, I thought I knew what euthanasia was before I came in here tonight, but now I'm not really so sure. In the context of the whole spectrum you just described, that's a quick question. But broader, this whole notion of capacity, I was wondering if you'd comment on that more, because I mean, who would be quote-unquote depressed if they found out they've only got 6 months to live? And so it seems like to be a very, in all seriousness, it seems like a very slippery slope between, well, I'm feeling great and they're about life, and therefore I'm confident to make a decision, even though I'm going to be gone in 6 months, versus, the opposite. And so can someone, in Judaism, if you don't have a rabbi, well, one rabbi says you go to another rabbi and ask their opinion. But quite seriously, according to law, can you shop docs and say, well, I need to find a doc, and maybe I need to find a psychiatrist who will do what I want them to do? So are there things like that? But in general, my question is really about this whole capacity, because it seems like once you've lost capacity, that's what people are really scared of.
I think it is true that a category of people who were concerned to have the law enacted were in the category who most feared that loss of control and mental ability. I'm going to defer on the depression issue to Dr. Genzini, who is, after all, a psychiatrist, but just to comment that there is a difference between feeling sad because you've gotten very bad news and being depressed to the point that your decision-making capacity is seriously impaired. On the euthanasia issue, in U.S. law, as far as I'm familiar, and there are a lot of other lawyers here that can tell me, we didn't start off with a definition of euthanasia. We simply regarded homicide as the category, and there is criminal homicide, and there's justifiable homicide, and so forth. And the understanding was any intentional taking of a human life would be a homicide, and the term euthanasia was really being brought in from the outside by people who wanted to say there are categories that should be acceptable. It is a good death, euthanasia. And for a time in the 19-teens, 20s, 30s, there was a good deal of interest in that. It got a very bad reputation because the Nazis announced that their program was a euthanasia program, and so it was associated with all the other crimes against humanity and so forth. The Euthanasia Educational Council in the United States changed its name to Concern for Dying. First, Concern for Dying first, and then Choice in Dying thereafter. And so there isn't a legal definition, really, but the example I gave is if I or anyone else under this law gave someone the pill, put it in their mouth, didn't give the prescription, didn't even put the bottle by the bedside, that's okay, as far as I would think, as far as I know, that's even explicitly covered. But if I put it in the mouth and held up the glass, and it was my hand holding the glass, even though it's their throat swallowing, I believe that would be regarded as I have taken their life and I'm not protected under this statute. And I'd be open to anybody telling me otherwise. And if I were doing it because I was doing something evil, people might say it's just outright first-degree murder. If I'm doing it in a loving way because I know this person wants that result and they've asked for it and they just physically can't get it, someone might say, well, that was a mercy killing. That was a euthanasia. And I know from talking to people in the AIDS community and at least one prosecutor in the 1980s that they knew that was going on at a time before there was any decent treatment and there were horrible deaths. And they just said, we're going to look at these circumstances, and if we think it was being done out of that kind of protective thing, we're just not going to bring these cases. And we didn't have prosecutions of people, and yet we know that those cases were even written up by some of the participants. They described helping people to die. And it was just felt, this is a horrible situation, and we're not changing the law, but we're just not regarding those as cases where, where we're going to prosecute. And what the prosecutor told me was, we couldn't get a conviction. It would be such a sympathetic situation, you know.
Do you want to comment on impaired judgment and whether there's doctor shopping?
Yes, so the issue with depression is in medicine, we distinguish, well, what we're really worried about is clinical depression or major depression, where people are sad, blue, depressed for most of the time over several weeks, a minimum of a couple of weeks. So it's really quite impactful. And that is different than being terminally ill, having bad days, feeling sad, feeling discouraged at times. About between 10 and 20% of people with a terminal illness will get major depression. But it's actually more interesting how many don't. And I remember doing one of my first studies in this area of patients with amyotrophic lateral sclerosis. This is a group of patients who are 30 times more likely in Oregon to choose physician-assisted death. And we used the Beck Hopelessness Scale. And one of the questions is, does tomorrow look better to you than today? And 80% of ALS patients said tomorrow looked better than today. to them. So I think even in the face of terminal illness, people maintain ability to enjoy their life, to have pleasure, to feel hopeful, and that it's not necessary for people to get depression. Now, before I ever got into looking at physician aid in dying, and the reason I got into it is because I happened to be in the mid-90s doing studies of patients with major depression to see if treatment of depression made them more accepting of life-sustaining treatments, things like dialysis and mechanical ventilation. So these were just surveys. And what we found was major depression was only impactful if it was very severe and if it was so obviously associated with this very obvious distortions around their life or really severe apathy. So it was only a small number of cases where treatment of depression changed people's minds. Just one other thing about the California and the Oregon law, it doesn't exclude people with depression. It excludes people with depression impacting their judgment. And I have to tell you, as a psychiatrist, I'm pretty damn good at diagnosing depression. But I am not very good at all in these cases of figuring out whether it's affecting somebody's decision. I think that's quite difficult. And so what we end up doing is excluding everybody with depression because we really just have to assume it's impacting their decision.
And that was one of the major concerns at SC about physicians thinking about whether they would participate in this act, is feeling that they may not have the skills to know how much a comorbid mental health issue is influencing capacity. And the law doesn't mandate any involvement from a psychiatrist or a PhD in psychology. It's an optional consult, but it's not mandated.
And if I were to mandate a psychiatry consult versus a palliative care consult, that's an easy one. Make the palliative care required, not psychiatry.
We have about 5 minutes left. See if we can ask questions.
The question I want to ask Dr. Yancini is this: is there any difference? John Myers. I'm reading through policies for hospitals right now in this area, and responsible for University Hospital. So the question that I have for you is there a difference between the California and Oregon laws such that under the California laws you would expect a change in the empirical results that you got? And if so, what you think and why?
Right. So there are, I think, really quite minor differences between the law that I don't think are substantive. But I do think there's differences between California and Oregon. So
That's why you have a wall at your southern border.
So California is much more heterogeneous than Oregon is. And at the time the law passed, I think Oregon was, 94% Caucasian. And so I think that there's potential lack of generalizability of our data to the California experience. I think that's the major one. So I would really encourage more research to go on and just not assume that what we found will be the same.
Do you have a question here?
I'll ask a second question. Shane Huey, Environmental Health Sciences, School of Public Health. As a public health person and involved with training students, I want to ask the panel, how did the law in Oregon kind of affect any training of students coming through nursing, medicine, and public health? What do the California people think that should be done? Should this be done essentially through an ethics kind of focus or some other focus?
Well, to expand a little bit on what Dr. Capron said about Susan Toll, one of the other things that happened in Oregon when the law passed was that no hospital wanted to be on the front page of the Oregonian with a case of physician aid in dying where there was lack of access to palliative care. So every hospital, major hospital in Oregon, has a palliative care team. And when you have a palliative care team and a palliative care fellowship, then I think you have an opportunity to offer a systematic approach. Oh, and also ethics. I don't want to leave ethics. Oh gosh, I left ethics out. Really a systematic and comprehensive approach to training of medical students, residents, and fellows about end-of-life care. And we do have that in Oregon.
I think that's a really crucial question because, you know, as Dr. Capron was saying, some of the concepts about the ethics of, you know, for example, withholding a treatment or discontinuing a life-sustaining treatment, those are the types of things all the way along to the spectrum of when is someone eligible for hospice, what is hospice, what is palliative medicine, what's the End-of-Life Option Act. That whole spectrum of things has been it's ever more pressing to include, and from very early on. And I actually think that discussions about death and dying shouldn't just start in medical or nursing school, but should be actually a part of curriculums in colleges, like required curriculums, whether it's one class or part of a class. But it's a societal issue as well as one that's pertinent to those providing medical and nursing care. So, you know, I think most medical schools have some semblance of an ethics curriculum, and as we grow in palliative care and have more people who actually practice it, I think the hope is to have more penetration into medical schools, nursing schools, residents, fellows, and even, you know, fellow attendings who are practicing physicians who may not know how to talk about some of the issues that we've covered today. So the education, I think, is societal, outside of the walls of a medical school or a medical institution, but it's also very much within those who are learning to provide care for people.
This is a public health school forum. I'll ask one last question that is in that ilk. Health systems are now responsible for population health, for taking care of the sets of patients that they're responsible for. Certainly health systems can opt out, but those that don't, that are participating, do the systems have a responsibility to make sure that patients who request aid in dying have access to it?
Well, systems are made up of people, and the legislature, not just in this bill, but in previous bills, for example, there was a bill that began as something requiring physicians simply to describe all the end-of-life options, where the most extreme of the options was ceasing treatment. And that got watered down in the legislature so that if a physician were directly asked about them, they were supposed to answer. But the notion that you could have a law telling physicians that they should, with in appropriate circumstances as described with all these kinds of ends-of-life things, always raise and acquaint the patient with this, was defeated. And I have a sense that the law is as restricted as it is because most people think that as a matter of conscience, people should opt out. I think that when you put people together in systems, the system as a whole has that responsibility. And I know that there are systems where they are institutionally devoted to a particular point of view. And if that point of view is clear enough, and if patients actually have a choice of going to a different system and enrolling in a system that will give them more choices, then I think it may be reasonable to say even the system doesn't have to offer this. But I suspect that at least early on, this won't be something that you'll be thinking of when you sign up with XYZ insurer that has this or that panel of preferred physicians and hospitals, much less if you join a plan like Kaiser or something, where basically for most people who don't have very deep pockets, if it's not in your system, you're not going to get it. And so at that point, it seems to me we could say, system, figure out how you're going to do it. And I realize that would be very difficult for religiously affiliated systems. So it's not a final answer on my part, but I'm very sympathetic with people not having an opportunity to make the choice at the point where it really becomes then operative on them and they don't have a choice.
So in Oregon, there has been reticence to routinely let people know about the availability of physician-made and dying because of the worry that people will misconstrue that as saying, you know, this would, think about this as a cheaper option for the healthcare system. So that is not routinely done. And there was a couple of situations in which it was routinely done and it backfired quite considerably.
I think that a part of the system is to have accessibility and availability of all options for people. And I don't know that, you know, like Dr. Capron is saying, that advertising or making it known that the End of Life Option Act would be honored through a particular system is always going to work. But making sure that there's a better integrative, comprehensive approach for all options when someone is really sick or just got a bad diagnosis, including early palliative care. I think systems it's really incumbent on them to make that available, and I know that's the exception rather than the rule, unfortunately.
So not even a quarter of the year into the new, into this new act, and obviously this is a discussion that's just beginning, but I think we learned a lot from the insightful presentations of our panelists, and I'd like to thank them for coming to this evening. The next Paul Torrens Public Health Forum is October 26th, and thank you all for coming this evening.